if you guys can see this part here, I just want to show you this quickly. This is a PRF box basically. And what we do here, this comes this way. And when we remove this, when we draw blood, I'm going to put it in here, but this is kind of a pressure plate. So I want you to see this pressure plate. Obviously, I would be wearing gloves. The way we set up our kit is we place our PRF, all right, college pliers there like this, and so that we can grab our PRF out of our tubes, right? I'm only going to use 2 tubes here to show you, so it's nice and slender, goes in there. A lot of times, a lot of the physicians, a lot of the dentists want to use their own college pliers. Problem is that some of them are too wide, it doesn't fit all the way in. So what you want to do is make sure it fits all the way in there, okay? That's it. You need to have nice, sharp tissue scissors. That way you can cut the PRF membrane. And so I just wanted to show you that. Obviously, when you're going to start doing PRF, you need to learn how to draw blood. It's pretty basic. You know, we're all doctors, so we just have to learn how to do this. And we're all set. I'm going to show you now in the lecture. Also, sorry, I forgot. You're going to need butterfly needles here so that you can drain blood, so you can draw blood, sorry. And we can go forward. So it's the end of the day, so forgive me if I'm a little slow, but we're going to go fast on this one. Here you go. So this is a case presentation of PRF. A case presentation, basically, I did this on a patient. It was something that I was able to get all the photographs for and to present to you guys and show. So here we go. I'm going to do this quickly. This is PRF, and PRF is very simple to use. As long as you train properly, you'll be able to use it every day in your practice. And as far as productivity, you know, we all want to make some money, but the problem is that we want to also give the best possible treatment to our patients. And PRF has just enhanced everything. Once you incorporate it into your practice, you become fluent in it, you'll be able to do it all the time. So this is I'm showing you here implant placement, perforation of the buccal plate, bone grafting, particulate graft, and then the PRF is what looks like jelly over it. It looks like sushi. And PRF is platelet-rich fibrin. For all the dentists here, PRF forms a mesh. It's of platelets. It attracts macrophages, stem cells, and just stem cells, as we know, proliferate into bone or soft tissue, right, with signaling cells, and that's what we're going to get from PRF matrix. This is the way it looks when you're taking it out of the tube and it's prepared. It looks like sushi, and it acts like sushi. It moves around a lot. So I'm going to show you a little venipuncture video here, and it's kind of a little faster. That way you can just see how we're doing it. It's not supposed to be held the way I'm holding it here. I'm just doing it so that we can get a good video for it. When you get something called flash is what when the blood comes into the needle area, and then they start placing the tubes in there, the vacuum tube, so that we can draw blood. You normally go about 70%.
Are you going to get this hand out?
So you don't have to worry about this. I'll show you both videos. And what we're going to happen here is that both videos, again, some kind of warning here, so I'm going to lower that. So I'm just showing you here on the right screen, I missed. And I don't know if the participant missed or I missed, but you know, you tend to miss. Today in my own office, I missed 4 times. So it happens. Don't panic. It's okay. Right. And that's what it looks like when you're drawing blood. So the next thing here is the venipuncture one more time. All right. If you can't get one vein, you have to go to a different. That's the way you push the tubes in there. And that's the way it draws. Again, you want to have the label facing downward so that when you do, so when you draw blood, you can see how much blood you're getting. Sometimes the blood's coming out too slow, so you want to make sure you replace it. Now, this is the yellow tube. The yellow tube has an anticoagulant in it. They come in white also. So you want to draw that tube first because obviously you don't want it to coagulate. You want to get this to the centrifuge within 90 seconds. 90 seconds, it has to start spinning, right? So every 30 seconds, you got a certain percentage of cells that are dying. And you have to be on top of that because sometimes the team is talking to somebody or somehow they get stopped in the middle of the centrifuge area. And what happens is that they don't realize that 30 seconds goes really fast. So we remove the blood layer. It doesn't matter how much you leave on there, but the concentration, the highest concentration of platelets is between the yellow and the red. So you don't want to get too close to that transition there. That's the way it looks. See, sushi. You put it into the pressure plate, which I showed you before, and it's just a gentle pressure which will flatten these globules, you want to call them, out. And then that pressure plate removes the plasma that's in there, and it becomes a membrane. All right, and that membrane is what you're going to use to line your surgeries. That's what it looks like. It looks just like that when you're done. Now, those fluids that are there at the bottom of that box, you can use that to mix with bone also. So if you're going to do a bone graft, you want to utilize all that. And, you know, taking these courses is what you'll learn from constantly from different instructors. So right here, I'm mixing the plasma up and you're mixing with bone. That bone there is a 50-50 mix of a human bone and synthetic bone, or alloplast and allograft. If you remember that from our previous lectures, that will become solidified, and we call that sticky bone. See? So that's what we have there. Now, once again, I'm showing you the images, everything getting ready to go. I'm going to show you that it's a fibrin matrix. What becomes that fibrin, meaning the fiber of the PRF. And then it's polymerized, meaning that it just basically becomes hard. Not hard, but it becomes like almost like a little leather belt. You're going to see this on the slides. Everything it has is your cytokines, which are very good for our immune system, and all your leukocytes. You need all this stuff and these growth factors to enhance our hard tissue and soft tissue. Now, what's funny is that when I first started using this was 2005, and everybody was against it. But, you know, the science made sense. And, you know, as long as you follow what the literature says, you're safe. Always follow what the literature says, not what somebody else does. Okay. So here we go. This is a patient that came in here. If you can see this, I put down a date. She was 48 back then. To this day, everything is still fine. We're in 2024, and she's 48 years old. I just got to show you this, how you present it. That means the health history is all within normal limits. She is a smoker, which always, even if there's a history of smoking, you have to inform the patients that healing can be slightly delayed. Okay, everybody has a little martini on weekends, no allergies, and this is the biggest thing. You have to be aware of this. I'm the fourth dentist she went to. What does that mean? That means that she's gotten 3 other opinions, whether they're good or bad, doesn't matter. The point is she's very picky. She's probably educated in what she wants. So you have to be right on the spot there to give her the right information, not what you think is right, what's in the literature, and be able to quote it. So she shows up with this. So that's called a bone screw. Why does she have that? I have no idea. You know, where what happens is, what I'm guessing is she's gone to another dentist. They did a bone graft, an onlay graft, which is, we already know if you have bone, the jawbone, and they add bone to the top, you need something to tent it, to keep it up. But not just one screw. You need to do other types of procedures here. Whoever did that just didn't have their complete literature read. So here we go. So what we have here now is, I have a little video showing you the bone screw, okay? So showing you the bone screw. Sorry, I have somebody is helping me out. That's why you always hear me talking to people. And that's how far the bone screws out. So remember this also, and I always tell people this, you know, she says, well, can't you remove the screw now and I'll come back for the surgery? No, we don't know what's going to happen if you remove that screw and you're walking into something. Treatment's done all at once. Here we go again. So a little more literature here. Pre-medicate. Always pre-medicate your patients before any procedure. If you're going to do any kind of bone grafting procedure, okay, all the literature says you should medicate afterwards. You don't have to medicate if you're only placing an implant. Just pre-medicate. Motrin 800 is always good, or Tylenol, whatever the patient can take right afterwards. You don't need to use narcotics anymore like they used to. This is going to be as a 2-stage treatment. 2-stage means they place the implant first, and then 6 months later, you do the crown. So no temporary. As we go there, this is the procedure now, failed bone graft, and I'm showing you what she looks like now. Well, then. And this side note here, I'm showing you what exists there. So that little change in that wider part of that ridge shows me that they had some kind of bone graft done already. When? She wasn't very specific. And usually when they had it done, say, a year ago or 10 years ago, they don't want to tell you. They just don't. I don't know why. But that's what it looks like. So how much bone was added? We're going to see. So this is the bone that was added. This is before I even started treating her. This is not my treatment. right? And then now we have to look at what we did. When you're going to add bone, everybody believes that, oh, I'm just going to add bone, that's it. I'm going to just graft them. No, there's a lot involved. There's soft tissue reflection. You need to learn how to treat soft tissue before you even graft. So there's a certain type of reflection that when you're going to advance it. Remember, if you're adding bone to a surface, you're increasing the circumference of that ridge. That means when you pull the soft tissue, it's going to be tight. So you need to release it. How are we going to release that? That's an incision design. So all this is taught in the Long Island MaxiCourse. All this is taught in most courses that are preparing you for not just implants, but overall soft tissue design. And you need to learn that. Pick the right course, okay? And take many courses. Take a course every year. But this is the way it looks. This is the way incision was. That was my incision design. And the reason why we do that, you see that orange point, red point, when you advance it, right, the point moves forward. And that moves forward, we get closure. Now, that looks like an aggressive approach to doing a graft. And somebody's going to tell you, everybody has a different opinion. They're going to tell you, oh, just do a V and you should be just fine that way. You know, this works the best because when you advance it, there's no tension, right? So that's what I'm talking about. And the literature shows it. So it's not my opinion, it's the literature. So you have to cross over a little onto the palate. Remember, you have to give yourself a little freedom if you're going to leave it open. It's going to heal by secondary intentions. Secondary intentions, if you guys remember that, secondary intentions is when you do not get primary closure. You're slightly apart, and now the soft tissue has to grow in. Always do pupilla sparing in the front, you know, and if you don't need it, do it anyway. It gives you good practice. All right, periosteal release tension. Periosteal release is the way you cut the periosteum there so that you can advance the tissue. If you don't cut the periosteum, it will not advance. There'll be tension. And that's the way it looks. And I'll show you how it's done. All right, it may look simple, but I've done so many of them that we go forward and you can just do it this simple. Always a new blade. So if you can appreciate this, you know, there are little tight spots there in the corner that you have to go back and incise. You don't want to keep on cutting it like if it was filleting fish. You don't want to do. You want to do one clean sweep. That's why you need at least two blades when you're doing this, right? One to do the outline, the other one to release the periosteum. And you want to release the periosteum before you do the bone graft because there's going to be blood. So you want it to kind of calm down by the time you're grafting. So all this is taught. Remember, you need to take classes, all right? As we go forward, you're going to see that. Let me see what else I can show you here. This is the way the design looks. I just wanted to do that in basic terms. That way you don't look at all the soft tissue. You got point A, you got point B, and then they're going to come down, and that's where it meets as you advance it. So when you pull it, you know, coronally towards the teeth, you'll see it comes forward that way, and all that tissue is covering your bone graft. So now what we used to do is just graft and close, and you would have to use a membrane. If you use a membrane, any kind of resorbable membrane or amniotic membrane, anything you want to use, resorbable, it's great, but it adds to your costs. So that's a whole different lecture on costs. Because remember, if you're going to buy a membrane, it's about $150. And even if you get it for $100, it's fine. But if you're going to do PRF, every time you do that setup, it's only 20 bucks. All right. And if you need another membrane, you just take more blood out. Okay, you don't have to have somebody come to sell it to you at the office. But I have both membranes just in case I can't draw the blood. So it's always good to have both. You have to be prepared for anything. So this is the old way of doing things. Now with the Yomi robot, I don't have to have a guide pin anymore. So what we do with the Yomi robot is everything is done on the CT scan. So when I'm going in there, I don't need to take a guide pin. I'm going to start to finish with the implant placement. But this is the guide pin. A lot of people still do this. You know, I still do it every once in a while in my other office because I do not have a Yomi over there. As you can tell, this thin buccal plate here. So sometimes people say, well, you can actually place the implant more palatally. You know, you can't, but now you're going to start getting into a prosthetic problem, right? So we have limitations, and we know that our limitation here was the thin buccal plate. So we have to perforate the plate anyway, and then that's just to create some, it's called a wrap phenomenon. And as we already predicted this implant coming through the buccal plate, and we were going to add bone to it, right? It was all expected. Everything is planned. We know exactly what's going to happen, and you should know what the outcome before you start. So let's go over stuff. That was the bone screw that we removed, which is 10 millimeters, just to show you the length of it. And then my glasses kind of fogged up a little bit. Sorry. And then that's the incision design. That was the guide pin with the thin plate. This here is the bone graft, always overgraft, because you're always going to get a little bit of resorption. That is the PRF membrane that I'm placing over that. Now, over that PRF membrane, I'm going to put the flap over that, and it closes up, and it looks really bulky. And some people say, oh, that looks like a mess. You know, you can let people say anything they want. Never respond or never react, because as long as you're properly trained and you know what you're doing, you don't have to worry about anything. Remember, those that bark is because they don't know. Who barks louder? You know, a Chihuahua or a pit bull? So be a pit bull in life, okay? Right? 4 days later, this is what PRF does to you. If you do surgery and you don't use PRF, you know how that soft tissue looks, especially if you're doing a full thickness flap. So that's the way it looks. Today, I use PTFE membranes. Okay, I mean, sorry, PTFE sutures. That's Vicryl, but that's 4 days later. That's 4 days after this bone graft implant PRF procedure, because the PRF just blends into the soft tissue. That's the way it looks. What is that? 7 weeks later, 8 weeks later. All right. And that's how the tissue is looking. Now, people are going to say, well, that doesn't look that great. It's in the healing process. All soft tissue takes at least 12 weeks to properly heal. That's the way she looks. That's the way we started. That's 18 months post-op right here. Look at that. Do you see any big bulky? That's where the PRF was. And that's a year and a half later, post-op, right? That's post-surgery. I think that looks pretty good. All right, that's the implant. Now somebody's going to critique it. Oh, well, look at the bone resorption. This is done so many years ago. It still looks the same way. Right? 7 months post-load. All right, and this is 5 years post-op. 5 years later, you can't even tell there was a bone graft there, but there is thick tissue. All right, and the CT scan shows it to me. I don't know if I have a CT scan here, but this is onlay graft resorbable HA. I get the resorbable HA. Now, I'm going to tell you what I use. I use Oxygen plugs, and I use resorbable HA from Implodent. I use that because all the literature shows that you can use this, you know, alloplast instead of using regular human cadaver bone, right? And get the same results. Once again, I'll always end off my lectures with me and my cup of coffee. I obviously don't wear the same suit every day, but that's my cup of coffee, and I enjoy my cup of Joe. Do that in the morning, think about your whole day. Forgive me if I look a little tired, but it was a long day today. That's my other message to you. You got to be able to pivot. Today, somebody came in and it was an emergency, and they needed to have two molars pulled out on the same side, 30 and 31. And 3 other dentists in the area didn't want to do it because she had too much of infection going on there. She called an old surgeon. The old surgeon says, I don't have time for 2 weeks. So she called me, can I do it? I go, if you don't mind waiting, I will work on you. So right away, she got 2 grams of bone in there. Everything's grafted. You know, she went up to the front, took care of everything. You know, you have to be able to pivot in your practice. So I did everything from orthodontics today to lip fillers to Botox. And then I ended off the day with bone grafting. All right. So that's what you have to do so you can go forward, keep on top, be that guy that everybody wants to come and ask their opinion. It only took me 30 years to get here, though. So don't think that it's something you can do tomorrow. All right. Peace out, everybody. Love you. I'm Dr. Mike, Implant Mike, Dr. Mike Calderón. Ciao. Don't forget, never give up.